Thank you very much for this invitation to speak at this conference. I'm back here after a long time, and I must say I've missed it because I consider PCSI as my baby from the time we first started it. And that brings me to Biswajit Banerjee, or Bisban as we affectionately called him. So those were really heady times in the late 1990s, and now I'm dating myself, when we basically got together at the CSI in 1997 and started the Pediatric Cardiac Society of India. That was when it was born. And then the talks about starting fellowship programs, and we got our first accredited fellowship going between All India Institute and Madras Medical Mission. And Biswajit was in the first batch of accredited pediatric cardiology fellows, and along with him were Sejal, Bhagyavati, and Kshitij Sharma. And those were my first 4 accredited fellows, and what wonderful times we had. And so it's really a deep honor to pay tribute to Biswajit. So I'm going to start with a little poem which I really pulled from the internet. The angels looked down from heaven at night. They searched for miles afar, and deep within the distance, they could see a shining star. They knew that very instant that the star was theirs to gain. So they took you up to heaven forever to remain. Look down on us from heaven, keep us free from hurt and pain. You'll always be within our hearts until we meet again. Okay, so when I was asked to speak about Biswajit, I actually messaged all his co-fellows because I hadn't seen him in a long time. And unanimously, everyone gave me the same comments about Biswajit, about how his smile would light up every room, how he was always smiling, always happy and bubbly, and equally assisted by his wife, Swati, who also always had this fantastic, beautiful smile on her face. And the two of them would really light up every room they attended. And my first 4 fellows were the best fellows ever because they had such a good camaraderie between them, and each one of them were unique but wonderful. And Biswajit was a wonderful, wonderful life partner to Swati, as you can see from these pictures. He also was a very wonderful father, and this family was always together. And I remember how proud he was when his daughter, Sudeshna Tuli, was born. And I remember him telling Kshitij that you are my good luck charm, because Kshitij also told him when he passed his exams and got in there. So Biswajit had, I'm sure his family have wonderful memories of Biswajit with them, and he must be so sorely missed. All right, so I'm going to have you all guess who is Biswajit in this group. So this picture, of course, I filched from Facebook, as I pulled some other pictures too. And so this is Biswajit and his classmates from college time, and many of them are married to each other from this group, which is not surprising. So this, I believe, is Biswajit, if the Facebook tag is right. And he was about 10 sizes smaller than what he was when I knew him a few years after this. And the beautiful lady down here is Swati, who looks just the same. So these were, like I said, wonderful times with my fellows, and we were nearly the same age. I was just a little bit older than them because I had just come back from my fellowship in the US, and I started the fellowship in India. So it was not that huge a time period difference. And here is Biswajit. It was me, Bhagyavati, Sharda, who was my colleague, Sejal, Kshitij, and Dr. Murthy. And we also had a lot of picnics, and we went to the beach and had a lot of fun, as you can see here. This was several years later. You can see the gray mustache and graying hair in Biswajit, but if you see, the two women look the same as we looked here, but Biswajit definitely aged and grew apart. So this is a word art that I got from his co-fellows and also from Dr. Amitabh. So bright, genuine, kind, considerate, street smart, dedicated, pious. Apparently, he never started a day without a puja. loving husband and partner, great friend. And what I don't have here is that he was apparently a great cook, though I haven't tried his cuisine. I'm vegetarian, so I probably would not have eaten a lot of the fish. So gone, Biswajit, but never forgotten, and always in our hearts. So that brings me to my talk today, risk stratification in pediatric pulmonary hypertension. So for this talk, I have no disclosures. And again, I'm honored to do this talk, and I'll thank the organizers because this got me thinking a lot. This is not one of my usual talks. All right, so if you look at this, the question is, why do you need to risk stratify? We don't risk stratify every disease. So we could be like the old-time clinician saying, I know everything. When a patient walks into the room, I know how long this person has to live, or what my clinical judgment exceeds everything else, and why am I spending so much money trying to risk stratify? So that is what we all thought about in pulmonary hypertension. But the thought of low risk, medium risk, high risk actually came up about at least 8 or 10 years ago, when people realized that you have to make use of technology and other tools to decide on what is the best way of attacking this disease and prolonging life in these patients. So the truth about the disease is that there is a very unacceptable 7-year survival rate. If you see, it's just all downhill. And this is even with patients being treated. So you really have to be appropriate in how you treat them. Clinical progression continues to occur despite improvements in 1-year survival. So pulmonary hypertension is a disease with very high mortality and poor prognosis. History and physical exam and clinical gestalt does not reveal all. Right heart cath or cardiopulmonary exercise test or echo alone do not predict outcome accurately, so we have to use a combination of tools. Risk stratification allows us to guide appropriate therapy at the right time. That is important. It's not just what you give, but how you give it and how you attack. The goal is to risk stratify, treat the patient appropriately, review and re-stratify at 3 to 6 months, and then tailor therapy. So the goal is to move from higher risk to lower risk and try and remain there. So there are many things that we do. There are many tools that we use. So patient demographics, including age and gender, WHO functional class, functional capacity, which is measured using exercise testing, hemodynamics by cardiac cath, right heart cath, which you might have to repeat after you start therapy when you review the patient. Biomarkers, estimates of perfusion, right ventricular imaging using echo and MRI, which should be more and more used. Genomics, one of the most important things to use for risk stratification should be genomics, and it's not yet in most equations. And then comes risk equations and tables. So to assess risk, you have to use multidimensional risk assessment tools. So let's look at them. Starting from left to right, biochemical markers, clinical assessment, really important, your functional class, history of syncope, how have the symptoms progressed, what are the overt or covert signs of right heart failure, exercise testing to give you an objective way of looking at the patient's functional capacity, echocardiographic evaluations for right atrial area and effusion, but also definitely what's missing here is right ventricular health, hemodynamic evaluations, including right atrial pressures, pulmonary hemodynamics, cardiac index. So let's look at the REVEAL score. This was, REVEAL is a registry that included about 3,600 patients, of whom 2,700 had enough parameters that we could do risk scoring. It's a validated 12-pronged variable tool, which stratifies 1-year mortality risk in 5 strata. So 5 strata meaning low risk, intermediate, a little higher level, intermediate, and then the high risk categories. If utilized appropriately at follow-up, it predicts outcome at 1 additional year. So that was for prevalent patients also. So it's incident patients and prevalent patients after 1 year. 12 independent predictors of survival were identified and a prognostic equation was generated. So this was 12 to 13 parameters. So this became cumbersome. So there was a search to see whether we could use lesser parameters and still predict appropriately. So the simplified reveal light risk score was developed from the reveal equation, and it was not found to be significantly different in its predictability. And reveal light again has 6 parameters. I cannot move my slides. Okay. So this is the reveal risk score calculator. And this can be downloaded to your smartphones, or it can be part of the electronic medical record. And if you look on to this side are the WHO subgroup demographics, NYHA functional class, vital signs, and all of the scoring. And it goes from negative to positive scores, and you write what the score is, or you click on this and it shows up here. And negative scoring, meaning the patient is at very low risk, and the higher the score, the patient's risk goes up. So then you can easily stratify patients, and the patients separate into a score of 1 to 7, which is the lowest risk, and more than 12, which is the highest risk. And if you look at outcome at 1 year, this is 12 months, not 12 years. Look at the mortality here. So survival was 66% at 1 year for the highest risk, whereas it was nearly 98% in the lowest risk strata. So this is baseline risk scoring, and this is at follow-up. So this was the initial patients retrospectively looked at and then risk scored and saw what happened to them at 1 year. And then they were re-stratified and looked at and then separated out. And as you can see, the ones in the lowest risk are alive still another year later. And the highest risk, they are now less than 50% alive after 1 year. So if you look at the two scores, this was the one with the 13 variables, and this is the one with the 6 variables. So the 6 variables that reveal light uses are the renal insufficiency, it should not be at the top, functional class, vital signs, 6-minute walk distance, biomarkers. These are the scoring. And vital signs includes a systolic blood pressure less than 110. Now remember, this is adult scoring and not pediatric scoring. Heart rate more than 96. Both of these add a +1 point. And then you sum the scores totally and see where you are. Again, this is our reveal calculator, but there are multiple such calculators. So from Europe, using the European Society of Cardiology and Respiratory Society, the Compera score was devised, again, 6 parameters. Swedish, French, and Bologna scoring, all with 6 parameters each. And if you look at them, they're all looking to show you the same thing. The Swedish, the French, and the Compera, basically you're trying to investigate the discriminatory ability of risk assessment and see whether there's a potential prognostic advantage of a low risk profile, and then how do you decide on how you're going to treat them. And if you look at specific parameters, is 440 better or 300 better? Meaning you need to really find an exact, a good cutoff point where you change your scoring. Same thing with the biomarkers. So all of these different groups of people have been looking at different scores to see what's the best way. And what we need to do is really come up with a scoring that's unique to pediatrics. And if any of you are interested, we could really do a multinational, multicentric scoring and try and figure out something good. Okay, so this is the old ERS ESC scoring, and low risk, intermediate risk, and high risk. Again, the mortality, estimated 1-year mortality is less than 5 to 10, and more than 10. These are the 3 important registries from Europe, the Swedish, the French, and the Compera registry. And you can see how each of them, using slightly different parameters and slightly different number of strata, are separating out patients into different risk groups. Okay, so if you look at the summary of the 3, if you look at Swedish, Compera, and French, what is different is the last 3 parameters, the low risk, percentage of low risk at follow-up, And it seems like the French group had a higher number of patients with initial combination therapy and a lower number of initial monotherapy as compared to the other two groups. And there were a higher number of patients who remained at low risk at their 1-year follow-up, which says something about hitting them hard and using multiple medications and trying to treat it. And this is something that pulmonary hypertension specialists have really learned from our oncology colleagues, where you really hit them hard and you get good results and keep them good for a long time. So this is the European Society, again, the Compare risk score. If you look, they really highlight which ones are at high risk, and it's really intuitive what they're using, but these numbers may be somewhat important to use when we are trying to stratify patients, and we need to come up with what's happening in pediatrics. So what happens when you calculate the risk score? You estimate them to ERS, which is compare low risk, or reveal a score of less than 7. Intermediate risk, high risk, and very high risk. So if you start with the low risk group, you consider mono or upfront 2-drug therapy and start referring them to a comprehensive care center. If it is an intermediate risk or reveal score of more than 8, definitely refer to a center of comprehensive care for upfront dual or triple combination therapy. If it is ERS high risk, they probably are already referred to the Center of Comprehensive Care, but add intravenous prostacyclins to them. And I know in India, it's really hard to get intravenous prostacyclin and it is exorbitant, but use of oral prostacyclin receptor agonist may be a good substitute. And I know it's available and in good use, because one of my own patients is being treated by Prashant Bopte with oral selexipag. And that is a possibility. ERS very high risk or reveal more than 12, they should be referred to a comprehensive care center. Consider mechanical assist, balloon atrial septostomy. What's not here is a POTS shunt and a referral for lung transplantation. Please reassess every 3 to 4 months. I'm not saying cath every 3 to 4 months, but evaluate, see the patient every 3 to 4 months and try and see if they've changed their reveal scoring. If the treatment goals are not met, then you have to wonder what you're doing wrong and if you need to add something more. Escalation of therapy may be required based on risk. So this again is a similar slide which just tells us what we are doing, but it also includes the vasoreactivity test. And really the 10 to 15% of patients who are vasoresponsive are phenotypically different. And I think they very happily go into the low risk criteria, and their long-term survival is very different from the ones who are not vasoresponsive. And so if we go back to the non-vasoresponsive patients, then we are using the same treatment algorithm that we used earlier, which is basically risk stratify, treat, aggressively treat, follow them up, re-stratify them, and decide what you're doing at your re-stratification. So what is the relevance of risk scoring to pediatric pulmonary arterial hypertension? So all these studies were initially and basically done for idiopathic pulmonary arterial hypertension, or at least group 1 PAH, which would include connective tissue disease, your scleroderma patients, and maybe your portopulmonary hypertension, though they're not all the same. And the risk stratification, which fits for idiopathic, may not fit for hereditary or genetically positive pulmonary arterial hypertension, and may not be the same for portopulmonary. So there's a lot of leeway here for us to actually look even deeper and dive deep and see what we can separate them out more. Also, they're not relevant for group 3 pulmonary hypertension with increasing survival of extreme premature patients. Almost 50% of pediatric pulmonary hypertension are growing BPD patients. Again, extrapolating to congenital heart disease is a little tricky because every congenital heart disease is different. So, but we can use the criteria and treat them and follow them closely. So basic principle of pediatric therapy is unchanged from adults. We need to add a risk calculator to our electronic medical records, use it on our phones, add it to the patient notes. So your referring cardiologist or referring pediatrician knows what we're talking about and what the rationale is for using so many medications, because sometimes people are very suspicious when doctors start treating patients with a lot of medications. They either go away and get a second opinion or not take the medication. So it's part of, you can show your patient, this is where you fall. And if you don't take these medications, you may not make it. Consider adding RV function. RV health is really, really important. So our right ventricular function parameters should be included for the next iteration of risk scores. So I don't want to take too much of your time. Thank you so much for your kind attention. And I'm so honored and so pleased to be part of this conference. Thank you very much.